difficult to stop the spread of this disease. The second hearing we had, which was last Thursday, was on mitigation, largely looking at testing, and this was last Thursday after the first community spread case hit my home county of Sacramento, where a patient was hospitalized at the University of California, Davis Health System, where I used to practice. What we discovered was, the testing criteria were probably too rigid, that we were missing a lot of community tests, and we also started to discover the ability to test folks, the availability of test kits, et cetera, was largely not there. I'm pleased to hear the Vice President yesterday. Things are ramping up, but we probably did lose quite a bit of time, and we are likely going to see many more community cases, probably in all of our congressional districts. So we still, there's a lot to be learned from kind of the bureaucratic breakdown that prevented us from rapidly getting those tests out there. Today's hearing is focused on treatment based on science and what we can learn from how this virus initially developed, what we can learn from looking at the Chinese response. We now have a big data set. How did they manage folks? China is a communist country, so they were able to do things that we can't do as a democratic nation. We respect individual rights and individual freedoms here, but there is still a lot that we can learn from how they did surveillance, et cetera, especially given the breadth of contact tracing that we likely are going to have to do based on the community cases that we're going to see all across the United States. We won't have enough epidemiologists. The CDC won't have enough personnel. So what can we learn in how China and Korea, and if you're looking at the data that's coming out of Korea now, their aggressive approach to testing and community-based testing, they were doing 15,000 tests a day, may have actually mitigated and reduced how bad the response could have been. So I think that's going to be incredibly important. We're also going to look at the science of, how is this spread? How efficiently is it spread? How long can this virus live as a fomite on inanimate objects? So, I think this is an incredibly timely hearing. I think this is, this is the Science Committee, so I'm glad that we're looking at the science of this and the science basis of treatment. And again, I appreciate the witnesses that are here that are bringing their scientific expertise to help us better understand this disease. With that, the chair now recognizes the ranking member, Mr. Lucas, for his opening statement.
Good morning, and thank you, Dr. Barra, for holding this important hearing as we deal with an emerging and rapidly evolving situation with the spread of coronavirus, COVID-19. According to the Centers for Disease Control at this time, most people in the United States have little immediate risk of exposure to the virus. However, public health experts also advise us a pandemic is likely, so we must gather the facts and be prepared. Today, I hope our expert witnesses can provide important information we can share with our constituents. I also hope we can learn what tools are needed to detect, predict, and prevent the next pandemic. COVID-19 was first identified in Wuhan, China in December of 2019. Since then, the World Health Organization has reported over 90,000 confirmed cases and over 3,000 deaths spread throughout 76 countries. In the United States, the CDC has reported at least 152 confirmed cases and 11 deaths. We know that for most individuals, the illness is not serious, but we're still getting information on the death rate. The impact on vulnerable populations is particularly concerning, though, and my thoughts are with the individuals and families that have been affected. This is not the first global pandemic in modern times, and I'm quite certain it won't be the last. Just over 100 years ago, the world faced one of the deadliest pandemics in history, the 1918 avian flu pandemic, also known as the Spanish flu. It killed an estimated 50 million people worldwide, including over 600,000 people in the United States. Since 1980, outbreaks of emerging infectious diseases have been occurring with greater frequency and have been causing higher numbers of human infections than in the past. The vast majority of these infections are initially caused by the spread of the disease from animals to humans. A SARS outbreak in 2003 and an avian flu outbreak in 2006 were wake-up calls for the American public health system, and Congress made considerable investments in improving our nation's capacity to detect and respond to pandemics. We would be in a much worse position without those investments. I'm confident that the U.S. government has the tools necessary to deal with this. We have the best scientists in the world with NIH, CDC, and in our universities. Their work has yielded considerable advancements in health technology, disease surveillance, and predictive modeling, as well as medicine, drugs, and vaccine development. With the integration of technology like artificial intelligence and the greater availability of data, researchers are now able to identify and track outbreaks faster. Last Congress, we also modernized the Pandemic All Hazards Preparedness Act to set up a framework to deal with precisely this type of outbreak. While significant progress has been made, gaps remain, and a severe pandemic like the novel coronavirus could be devastating to the global population. As the human population has grown, so has the livestock, swine, and poultry populations needed to feed us. This expanded number of hosts provides increased opportunities for viruses from birds, cattle, and pigs to spread, evolve, and infect people. To better understand how zoonotic diseases like avian flu, swine flu, Ebola, Zika, SARS, and now coronavirus spread and operate, we must invest in basic research to learn more about the interconnection between people, animals, and plants in shared environments. Yesterday, the House passed a supplemental appropriation bill to address the response and the development of a vaccine. I supported the bipartisan bill, and I hope my colleagues and I can work together on a long-term strategy to prepare for any global pandemic we may face in the future. Our top priority is the health and welfare of the American people. I'm pleased the President has created the Corona Task Force. This interagency group is working to monitor, contain, and mitigate the spread of the novel coronavirus while ensuring the American people have access to accurate and up-to-date health and travel information. The best thing Americans can do right now is to follow the guidance of CDC. Many of their recommendations are simple ones you'll learn from your mother. Wash your hands, do it thoroughly and frequently. Cover your mouth, cough or sneeze, avoid touching your face. Stay at home if you're sick. I want to thank the witnesses for taking the time to come here to share their expertise and insights with us during this crucial time to help keep Americans safe, healthy, and secure. And with that, I yield back the balance of my time, Mr. Chairman.
Thank you, Mr. Lucas. If there are members who wish to submit additional opening statements, your statements will be added to the record at this point. At this time, I'd like to introduce our witnesses. First, we have Dr. Susan Murray. Dr. Murray is the Program Director for the Global Health Program at the Smithsonian's National Zoo and Conservation Biology Institute. Next is Dr. John Brownstein. Dr. Brownstein is the Chief Innovation Officer at Boston Children's Hospital and a professor at Harvard Medical School. Third, I welcome Dr. Peter Hotez, who will be introduced by the Chair for the Subcommittee on Energy, Lizzie Fletcher of Texas.
Thank you very much, Mr. Chairman. It's truly a privilege and a pleasure to introduce an internationally recognized physician scientist in global health, neglected tropical diseases, and vaccine development, who is also my neighbor and a true leader in our community in Houston, Dr. Peter Hotez. Dr. Hotez is professor and dean at Baylor College of Medicine and co-director of Texas Children's Hospital Center for Vaccine Development. As head of Texas Children's Center for Vaccine Development, he leads a team of product development partnership for developing new vaccines for a variety of diseases, including other human coronaviruses like SARS and MERS, diseases affecting hundreds of millions of children and adults worldwide, while championing access to vaccines globally and in the United States. Dr. Hotez, welcome. We are glad to have you here today.
And lastly, we have Dr. Tara Kirk-Sell. Dr. Sell is a senior scholar at Johns Hopkins Center for Health Security and is an assistant professor at Johns Hopkins Bloomberg School of Public Health. You will each have 5 minutes for your spoken testimony. Your written testimony will be included in the record for the hearing. When you have completed your spoken testimony, we'll begin with questions. Each member will have 5 minutes for questioning. Dr. Murray, you may proceed.
Thank you very much. Congressman Bera, Ranking Member Lucas, and all members of the esteemed committee, thank you for calling this hearing and inviting me to participate. My name is Dr. Suzanne Murray, and I'm the director of Smithsonian's Global Health Program based out of the National Zoological Park and Conservation Biology Institute. Our program utilizes experts in wildlife medicine, human medicine, public health, conservation biology, and epidemiology to study and respond to health issues at the human-animal interface. We utilize a multidisciplinary approach to investigate emerging infectious diseases that threaten both human and animal life, and we build in-country capacity to train the next generations of health specialists. In short, this is the reason right now that our program was created. Human health, wildlife, and environmental health are inextricably linked and closely dependent upon each other. In order to safeguard the survival of all species, it's critical that we examine health across a continuum of species and have research and decisions firmly rooted in scientific knowledge. Understanding the current viral threats, the patterns and drivers of disease emergence, and the human behaviors that contribute to such emergence will best allow us to not only respond to this outbreak, but the next one and the one after that, because we do know they're coming. Already, we have identified many of the drivers of disease emergence and spread, including land use change, increased human-wildlife interaction, and the globalization of travel and markets. Time and history have repeatedly shown us that it is much more humane, efficient, and economical to prevent disease rather than to identify, respond, diagnose, treat, and attempt to contain an outbreak. Through increased understanding of the as-yet undiagnosed viruses, the drivers of emergence, and the risk factors associated with various behaviors, we can develop the early warning systems, prepare rapid response teams, and provide critical data and information to the vaccine industry to better prepare for the next outbreak. Just as critical, we must educate local medical professionals and the people living in the communities at the greatest risk of outbreaks. By preventing the spread of pathogens at the source, we can avoid the global consequences that we are experiencing now. For example, over the last 10 years and working with partner agencies, our team has collectively identified over 1,200 novel mammalian viruses. So that's, 1,200 is a lot of viruses. It's only a small amount of the ones that are out there. 161 of these belong to the same family as COVID-19. In this time, we also strengthened the capability for virus detection and characterization in 60 labs in which pandemics are most likely to originate. We've also trained over 6,000 people in more than 30 countries at the front line of defense against emerging diseases. At this moment, the world is focused on the novel coronavirus, COVID-19, as it should be. While it's essential that we do everything we can to respond to this global crisis, it's also the time we need to be thinking of emerging viruses. The next global pandemic is not a matter of if, but when and where. To quickly identify and contain such infections, health and disease must be evaluated across species and on a global scale. While he might not have imagined it in this context, Ben Franklin was right when he said, "An ounce of prevention is worth a pound of cure." When it comes to outbreaks, the costs of responding to a crisis can dwarf the upfront investment in research and education. Beyond the clear moral obligation to protect human life, there are staggering financial benefits from focusing on preventative measures. For example, the human and economic toll from the West African Ebola outbreak was massive. More than 11,000 people lost their lives, and well over $4 billion was spent globally. In case of the SARS epidemic of 2004, the estimated global financial impact was between 30 and 50 US billion dollars, and the current COVID impact, while still evolving and a dynamic situation, is expected to be on orders of magnitude higher. Advancements in the detection of novel pathogens show that the most efficient way to respond to and contain an outbreak is through the coordinated wildlife and human surveillance. While we estimate there are 1.7 as yet unknown viruses, about half of which can infect human people, and some lead to new pandemics. As of now, there are no coordinated programs to work in high-risk regions to identify these unknown viruses. get their genetic sequences into labs, and identify ways to reduce risk of them emerging. Our best defense against spreading diseases that make their way into the human population is through research and education. While we cannot stop every disease outbreak, we can reduce their frequency and build the capacity for a rapid global response when they do occur. Thank you once again for this hearing and your interest in this pressing and important topic. I look forward to answering any questions you might have.
Congressman Barra, Ranking Member Lucas, and distinguished members of the U.S.
Dr. Brownstein, could you turn your mic on?
That would help. Congressman Barra, Ranking Member Lucas, and distinguished members of the U.S. House of Representatives Committee on Science, Space, and Technology, thank you for inviting me today to speak with you. Today, I'll describe ways that novel technologies like artificial intelligence can help detect, monitor, and predict emerging infectious diseases. I'll also discuss how non-traditional sources can supplement existing epidemiological techniques. But as I describe the good news about such advances, I don't want to sugarcoat the bad, for the current federal investments in disease surveillance are inadequate and transient. We urgently need federal and local investment in new technologies for public health surveillance and response. Such investment will augment the capacity of public health to implement new ways to monitor the health of populations. It will deepen our understanding of community-based morbidity and mortality. It will also save lives. This is the goal of my team at Boston Children's Hospital, where we develop innovative surveillance technology, where we use freely online information to provide insights to both public health agencies and the general public. We did this for the H1N1 influenza pandemic, H7N9 avian influenza, Ebola in West Africa, and now COVID-19. These platforms and our research have ultimately played a critical role in that innovative surveillance technologies can help detect, monitor, and ultimately mitigate the impact of these diseases. Our inaugural project, Health Map, which is available to the public, brings together disparate sources from a variety of data streams to help provide a unified view of the world of infectious diseases. To do that, we use AI, machine learning, natural language processing, all to organize that information and make it available. Here's an example. On December 30th, 2019, the platform alerted us to an unknown viral pneumonia. That turned out to be one of the earliest signals of the current COVID-19 outbreak. Using AI in modeling of epidemics is one of the areas of research offering vast insights into the potential burden of disease and where it spreads. Machine learning models can predict where a given virus may arrive next. That lets us inform public health organizations about how to respond. Predictive modeling can also be used with data like prior disease history, weather, travel patterns, laboratory data, symptom surveillance, all together through AI help us exchange information, conduct surveillance, and measure public response to the events and response. It is also critical to support sentinel surveillance of disease. Sentinel surveillance allows public health officials to identify signals early, impacts and disease burden in the community. One such example is Flu Near You, which is a crowdsourcing platform for symptom surveillance in the US. It offers two advantages. One, it identifies individuals who may be ill but not seeking medical attention, and it's in real time. Our team has now augmented this tool to improve with COVID-19 surveillance. To date, there's no evidence supporting widespread transmission of COVID-19 in the US, but does suggest that sustained transmission at the community level will be occurring. Current global situation suggests that this outbreak will become a pandemic. It threatens the health of the people of the United States and globally. The COVID-19 outbreak also demonstrates some reasons for optimism. It demonstrates what we can accomplish when the scientific and humanitarian disciplines unite around a common goal. We understand that each outbreak might require a slightly different approach to monitoring response, but there are key updates and metrics that we need in every single outbreak. There are questions that we must ask. How many new cases are there? What is the geographic spread? Are healthcare workers infected? We can help answer these questions by using both digital disease platforms along with traditional surveillance. We aggregate data from a variety of these sources in real time. There's an epidemiological expression that expresses what we want, prioritizing sensitivity over specificity. In English, this means that risking some false positives to uncover more of those who are sick. These platforms do that. They aggregate everything available to provide stakeholders with a snapshot of the current view of the situation. Those within the realm of infectious diseases often say it is not a matter of if, it's a matter of when. We continually need support for initiatives to make an impact both domestically and globally through infectious disease monitoring and surveillance. By investing in our neighbors and promoting health initiatives outside of our borders, we help reduce the threat of an outbreak reaching the United States. There's another essential step to being prepared: long-term support of the Centers for Disease Control and Prevention and for local departments of public health. The CDC's influenza surveillance systems are the backbone of flu surveillance for this country. Augmenting this surveillance system with novel programs like Health Map provides us with additional information. It allows the public health authorities, clinicians, researchers, and the general public to stay alert of what's happening. And this is why I urge this committee to make sure the United States provides sustained investment in the fundamental needs of disease detection and surveillance. That means investments domestically and around the world. Non-traditional data sources and enhanced data processing through AI and machine learning have proven their worth. They support traditional surveillance. They aid in the developing of a clear path and a picture of an existing or potential infectious disease threat to human health. You have shown through your thoughtful leadership on these issues in the past, and now we need your help again. For with your continued support, we can not only strengthen the public health community, we will protect the lives that we serve. Thank you again, and look forward to your questions.
Dr. Hotez.
Thank you very much, Dr. Berra, Congress Chairman Berra, Ranking Member Lucas, Congresswoman Lizzie Fletcher. Thank you for that very generous introduction. I'd also like to acknowledge my fellow Texan, Congressman Pete Olson. It's an honor to be here. I always get thrilled when I have the opportunity. I've been doing this for 20 years to address committees in Congress. It's still a special thrill for me. I'm a vaccine scientist and a pediatric scientist. I was previously chair of microbiology at George Washington University just down the road, and then a decade ago we moved to Texas to create a unique school for emerging and neglected tropical diseases, and also to create a unique center for vaccine development. And the need was this: there is an urgency to create vaccines for diseases which don't make money. So we took this on with the idea of pioneering not only the interesting science, but also a new business model. And the business model part we haven't quite figured out yet, because we're trying to make vaccines for diseases no one else will make. So we have a schistosomiasis vaccine now in clinical trials, a leishmaniasis vaccine that we hope will advance to the clinic soon, a hookworm vaccine in clinical trials, a new Chagas disease vaccine that's moving into the clinic. I like to say these are the most important diseases you've never heard of. These are some of the most common afflictions of the world's population, but they mostly occur among people who live in extreme poverty. And so there's no model to figure out who's going to pay for them. So as a consequence, neither the biotechs nor the big pharmaceutical companies make those vaccines. And for reasons that we'll explore this morning, we also took on a decade ago the interesting problem of making coronavirus vaccines, because we recognize these as enormous public health threats, and yet we have not seen the big pharma guys and the biotechs rushing into this space. So we partnered with a group at the New York Blood Center and the Galveston National Laboratory to take on the big scientific challenge of coronavirus vaccines. And I say a scientific challenge because one of the things that we're not hearing a lot about is the unique potential safety problem of coronavirus vaccines. This was first found in the early 1960s with the respiratory syncytial virus vaccines, and it was done here in Washington with the NIH and Children's National Medical Center, that some of those kids who got the vaccine actually did worse, and I believe there were 2 deaths in the consequence of that study. Because what happens with certain types of respiratory virus vaccines, you get immunized, and then when you get actually exposed to the virus, you get this kind of paradoxical immune enhancement phenomenon. And we don't entirely understand the basis of it, but we recognize that it's a real problem for certain respiratory virus vaccines. That killed the RSV program for decades. Now the Gates Foundation is taking it up again. But when we started developing coronavirus vaccines, and our colleagues, we noticed in laboratory animals that they started to show some of the same immune pathology that resembled what had happened 50 years earlier. So we said, oh my God, this is going to be problematic. But we collaborated with a unique group that figured out how to solve the problem, that if you narrow it down to the smallest subunit, the piece of what's called the receptor binding domain that docks with the receptor, you get protection, and you don't get that immune enhancement phenomena. So we were really excited about that, and we proposed this to the National Institute of Allergy and Infectious Diseases. They funded it, and we wound up actually making and manufacturing, in collaboration with Walter Reed Army Institute of Research, a first-generation SARS vaccine. So SARS was the one that emerged in 2003. And then this new one, of course, we call the SARS-2 coronavirus. We had it manufactured, but then we could never get the investment to take it beyond that. So that was really unfortunate, because we had the vaccine ready to go, but we couldn't move it into the clinic because of lack of funding, because by then nobody was interested in coronavirus vaccines. When the Chinese started putting up the data on bioRxiv in January, February, we saw very close homology between the two and realized that we may be sitting on a very attractive coronavirus vaccines. Now we're working with NIH, and we'll work with BARDA and others to get the funding, but now we'll have that lag. And these clinical trials are not going to go quickly because of that immune enhancement. It's going to take time. And so, and unfortunately, some of my colleagues in the biotech industry are making these inflated claims. You've seen this on the newspapers. We're going to have this vaccine in weeks, or in this and that. What they're really saying is they can move a vaccine into clinical trials, but this will not go quickly, because as we start vaccinating human volunteers, especially in areas where we have community transmission, we're going to have to proceed very slowly, very cautiously. The FDA is on top of that. They have a great team in place at the Center for Biologics Evaluation Research. They're aware of the problem, but it's not going to go quickly. We're going to have to follow this very slowly, cautiously, to make certain that we're not seeing that immune enhancement. So now we're hearing projections a year, 18 months. Who knows? This is not going to go quickly. The bottom line is, had we had those investments early on, to carry this all the way through clinical trials years ago, we could have had a vaccine ready to go. So we've got to figure out what the ecosystem is going to be to develop vaccines that are not going to make money. The big pharma companies are still not going in. Some of the biotechs are starting to, because they're trying to really accelerate their technology and use it, and hopefully to flip it around for something else that will make money. We need a new system in place, and I'm happy to explore that with you more during the questions and answers. Thank you.
Thanks, Dr. Hotez. Dr. Sell.
Good morning, Vice Chairman Barra, Ranking Member Lucas, and members of the committee. Thank you for inviting me to speak about my research on crowd forecasting and misinformation. This research in context of COVID-19 and ways to support research that improve outbreak response. Traditional disease surveillance is critical during infectious disease outbreaks. However, this information can be supported with tools to help support decision-making. One such tool is crowd forecasting. Crowd forecasting consolidates the diverse opinions of many into hard probabilities for future outcomes. This is helpful in gauging the most likely outcome, but also for understanding the uncertainty about that outcome. Over the past year, my research team, in partnership with a group called Hypermind, developed a crowdsourced disease prediction platform and asked forecasters to make predictions about outbreaks. For instance, we asked about the growth of Ebola in the DRC, the spread of measles in the United States, and how many U.S. counties might see cases of Eastern equine encephalitis. On most occasions, forecasters provided accurate predictions about 3 weeks ahead of time. Recently, we focused our forecasting platform on COVID-19. We asked about the number of countries that would have cases of COVID-19 and the number of cases that would be seen around the world and in the U.S. For global cases, forecasts showed high confidence that there would be a rapid and explosive spread. On a few occasions, our predictions were incorrect. We think this is probably because forecasters didn't have enough information to make accurate forecasts. Essentially, there's no magic here. If disease surveillance information is lacking or is delayed, forecasters don't have any information to go on. This underscores an essential research need for the current COVID-19 outbreak. That surveillance, both within the U.S. and globally, is essential. Another area of my research, misinformation during disease outbreaks, has emerged as a challenge during the COVID-19 outbreak and highlights the need to transparently and rapidly share information. Health misinformation can be defined as false health-related information and can range from the promotion of fake cures to rumors about the origin of the outbreak. Misinformation can substantially impede the effectiveness of public health response measures, increase societal discord, reduce trust in governments, leaders, and responders, and increase stigmatization. My team and I analyzed misinformation during the 2014 West African Ebola outbreak, one of the most recent examples of a fear-inducing disease event for the U.S. public. In our analysis, we found that about 10% of the Ebola-related tweets had false or half-true information. We also saw that more tweets with misinformation were political and seemed designed to promote discord. Another finding with parallels to COVID-19 was the identification of rumors, often focused on government conspiracies. Although we have not been able to do a systematic analysis of COVID-19 misinformation, we have seen the spread of false information, including recommendations for false cures that could be harmful, like drinking chlorine dioxide, blaming specific ethnic groups, and conspiracy theories about various governments creating the virus as a bioweapon. Response to misinformation requires a nuanced approach and further research to best determine the ways forward. While the solutions will be complex, one thing that is critical is the prevention of an information void that can be filled with false information. Members of the public need accurate and timely information to help them make sense of what is happening in the outbreak. As I advocated for improved disease surveillance earlier, this shows the need for a better collection and communication of disease information in a transparent and rapid manner. From my experience in conducting research in response to emerging disease outbreaks, I believe that we need to reduce the impediments and disincentives to doing rapid and timely research during these events. One hurdle to overcome is the slow process to establish federal funding streams for research during a response. My research was funded by awards from private groups prior to the outbreak, which provided the flexibility to shift gears towards COVID-19. And while the development of vaccines and countermeasures are critical, social, behavioral, and epidemiological research are also important. The best treatment cannot be effective without knowing where the disease is and who it is affecting. The best vaccine cannot change the course of an outbreak if people refuse to take it. And the best public health response cannot be implemented if members of the public don't cooperate. My bottom line message is this. We need to support the systematic collection and rapid dissemination of information about outbreaks. As the issue of misinformation grows, a dedicated effort to understanding the best ways to combat it will be needed. Even after the COVID-19 outbreak is over, emerging outbreaks will still be a continuing concern. The federal research space needs to evolve towards a more rapid approach to meet this threat. Thank you.
Thank you, Dr. Saul. Before we proceed, I'd like to bring the committee's attention to a letter that Chairwoman Johnson received in preparation for today's hearing. Letters from Johnson & Johnson and highlights their global response to the COVID-19 virus. Without objection, I'm placing this document and Chairwoman Johnson's opening statement in the record. At this point, we'll begin our first round of questions. The chair recognizes himself for 5 minutes. Dr. Hotez, you touched on some of your research into developing a coronavirus vaccine and a SARS vaccine. I think it's incredibly important since Dr. Sell just talked about information and misinformation. We've heard quite a bit about how quick we're going to get a vaccine, how quickly that'll be available to the public, and I think just this morning, I woke up to a news alert that said a Cambridge, Massachusetts biotech company had come up with a vaccine that they've sent to Dr. Fauci to start looking at testing and so forth. But I think we've got to be honest with the public so we don't give them false hope. And perhaps if you could just go through a timeline on what vaccine development is going to look like in the best case scenario, then to clinical trials, and then to potential public availability.
Sure, thank you for that question. So I think what we're going to see over the next few weeks to months is several vaccines will enter into a pipeline of clinical trials. Hopefully ours will be one of them. You mentioned the Moderna vaccine out of MIT. Theirs certainly will be in there. Probably Inovio is another one. There's about 5 or 6. J&J may have one as well. About 5 or 6, maybe a couple more. But then it's going to go into a bottleneck, and that bottleneck are the clinical trials, phase 1, phase 2, phase 3 trials. In spite of what the anti-vaccine lobby likes to claim that vaccines are not adequately tested for safety. In fact, among the pharmaceuticals, vaccines are the single most tested pharmaceuticals we have for safety, and it takes time. And because you have to initially do an injection in normal human volunteers, show that it's safe, and then you proceed stepwise to show that it actually works. And now, because of this immune enhancement phenomena, you have the added complexity because you want to make certain that those volunteers, when they're immunized in an area of community transmission, don't actually get worse. And so the FDA and CBER, which again, I can't emphasize enough how lucky America is to have that group, some of the best public health vaccine scientists in the world, are going to follow this very closely, stepwise. And
the best case scenario,
that's not quick, right? That's going to take
best
time.
case scenario, Dr. Hooks, and Dr. Fauci said at least 12 months.
He's definitely right, at least 12 months, but whether that means another year after that, maybe 2 years, it really depends on the safety signals that we're seeing with these vaccines.
Okay. And the ability of our commercial pharmaceutical sector to quickly ramp up and develop the vaccine and make it commercially available, is that going to be an issue, or do we have that?
Yeah, I mean,
as well?
there's a lot of being thrown out. There's a lot of press releases from the biotechs, and some of them I'm not very happy about, frankly, because I think it's telling only half the message. It took us years to develop our recombinant protein vaccines. It's an old method, but we know it works because we've had a hepatitis B vaccine licensed with this technology, the HPV vaccine licensed with this technology. Now you're seeing next generation platform vaccines like DNA and RNA vaccines. It's a very exciting technology because you can move very quickly into clinical trials. The problem is we don't have a single licensed vaccine with that technology. So the idea that all of a sudden this is going to work, historically, these have worked very well in mice and laboratory animals, but they haven't been reproducible in people. Organizations like Moderna and Novi say they've gotten around it. Now they've fixed this, so maybe they have. But it's still, we don't have a lot of experience.
We're moving at an incredibly rapid pace right now, but the public needs to understand that at best, there may be a vaccine in 12 months. It'll be longer.
Yeah, I mean,
potentially longer than that.
I mean, look at what happened with Ebola, right? We had, the first Ebola vaccine started being rolled out in 2015 in the epidemic in West Africa. It's not really till 2019 that we really got it rolling, which, by the way, is one of the most extraordinary public health stories ever told.
It absolutely
has 200, been. And thanks to BARDA and all these
Exactly. Let me ask Dr. Sell a question. You talked about information and misinformation. Based on your research, as you're observing this, what are some of the common misinformation that is out there on COVID-19?
Yeah, so I think that there's a range of different misinformation. So there's misinformation about false cures, and there aren't any cures right now, so all that is false. There's misinformation about sort of government conspiracies that someone else started the disease. And I think there's also misinformation about the disease, what characteristics it has. I think there's a lot that we don't know, and so there's that information void that people are just filling with their ideas.
So it behooves this institution and each of us as members of Congress to make sure we're in tight communication with our constituents back home. With that, let me recognize the ranking member, Mr. Lucas, for 5 minutes.
Thank you, Mr. Chairman. And Dr. Zotek, thinking about Dr. Sell's comments, let's begin from the parochial perspective, being your neighbor up north in Oklahoma. As of last night, the State Department of Health reports there are no confirmed positive cases of coronavirus in Oklahoma as of yesterday evening, although one Oklahoman showing symptoms is waiting on the test results from CDC. Can you discuss for a moment what we can share with our constituents back home to not instill panic and how to stress the importance of reasonable steps to prevent the spread? Yes, Doctor.
Peter Hotez. I know Oklahoma pretty well. My son graduated from OU, so just last year as a petroleum engineer. So it was a great place. We love Norman.
Absolutely.
The issue is this. I think in an attempt to calm public fears, you're hearing things like it's a mild illness, this is like flu. It's not really the case because this is an unusual virus. For many young people especially, it is a mild illness, but we're seeing some devastating things. And we got a heads up about this from the Chinese. They actually informed us, and we knew it was coming. Nursing homes. Look what this virus did in that nursing home in Kirkland, Washington. It rolled through it like a train, right? It's at least 7 deaths so far in a nursing home of about 100 people. So this is like the angel of death for older individuals. We need to go back and support all of our nursing home. I don't know what we're doing wrong, but clearly that nursing home is not prepared for this, and I'm going to guess nursing home across Oklahoma's are not prepared as well. Also, our healthcare providers. We saw in Wuhan 1,000 healthcare providers got sick, and we had at least 15% severely ill and in ICUs. And that is very dangerous because not only do you subtract those people out of the healthcare workforce, but the demoralizing effect of colleagues taking care of colleagues is going to be devastating. I mean, the whole thing can fall apart if that starts to happen. We saw this with Dallas. So I was on Governor Perry's task force for infectious diseases, and those 2 ICU nurses, when they got sick, it was really devastating. And finally, the governor had to call the Health and Human Services Secretary, CDC director, said, look, normal ICUs can't take care of these patients. We've got to get them out of here. So you don't want to see those kinds of situations. I'm worried about our first responders. We're already seeing in Washington State how they're already in quarantine. So does that mean we're going to have to bring in the National Guard? I think that's going to be another big issue as well. So those are the 3 vulnerabilities that I see right now in a place like Oklahoma.
And how should our constituents back home react to that, the average JQ public out there?
Well, I think the average GQ public needs to hear from its elected leaders, from the governor, from the public health authorities on what the plan is. I mean, don't just get up there and say this is a flu, this is a mild illness. One, it's not true, and people in Oklahoma are pretty smart. They'll figure that out pretty quickly. And second, explain what the risks are. These are the 3 vulnerable populations that we have to worry about, and here are the steps that we're doing to mitigate that. That's what people will appreciate.
Dr. Murray, as you mentioned in your opening statement, approximately 75% of emerging infectious diseases originate in zoonotic pathogens. You estimate there, you said 1.7 million unknown viruses yet to be discovered, around half of which are capable of infecting people. Could you expand, elaborate on the current state of research to improve surveillance in these diseases and where gaps may exist now as we look towards the future about addressing future challenges?
Yes, thank you very much, and I also appreciate that while we're trying our best to address the topic at hand of a lot of ill people, we do need to be thinking of the next virus and the next virus. I also think that the CDC has done a wonderful job of looking at and studying human health, and if we're going to do our best job to prevent future viruses from jumping, I think one of the missing components is indeed wildlife health. If 75% of the viruses come from wildlife, it makes sense that we look at that juncture of both wildlife and human health. We also, this virus is termed a novel virus, right? It's new. It's new to the people. I don't think it's new to the bats, and that's right. That's an important point. And then some of our other colleagues here have been talking about modeling and how important that is. Modeling gives us a greater information now as to what COVID will be doing within the U.S. and within other countries. We also have groups of modelers who look at the forefront, the stages before emergence, and look at the data that we have to try and determine where are the hot zones, what are the risk factors, and behaviorally, what are people doing to put themselves in danger? Those are really, really important ways for us to get ahead of the curve and catch the viruses before they come out. As part of the team that we've been on, which is a USAID program called PREDICT, we have a team of modelers who look at viral emergence, and they're able to determine for each different virus how many, as we collect more and more data, what percentage of the viruses that we know are characterized, and how many more are likely to be out there. Latest estimates are less than 1%, of the viruses we know are less than 1% of the viruses that are out there, meaning there's over 99% viruses in wildlife waiting to jump into humans. That's staggering, and that's really one of the things that we need to look at.
Thank you, Mr. Chairman. My time's expired.
The gentlelady from Oregon, Ms. Bonamici, is recognized for 5
Thank you,
minutes.
Dr. Barra and Ranking Member Lucas. This emergent coronavirus epidemic is a top concern for Oregonians, and I'm glad we're having this hearing today. In Oregon, we currently have 3 individuals who have tested positive, 2 of whom are in the district I represent. Plus, I have an additional couple of constituents still in Japan who had been on the cruise ship there. We know further community transmission is likely. It's clear from the tragic deaths in Washington how this virus can spread quickly and cause serious harm. And so let's take a moment to reflect on those who have lost their lives in our neighboring states of Washington, and now we understand there's a reported death in California as well. All the affected friends and family of those people. We need to take this seriously. I also want to recognize the tireless efforts of our public health officials in Oregon and the Pacific Northwest and across the country. I know they've been working around the clock to coordinate our response. For the past several days, I've spoken with our Governor, Kate Brown, and many state and county public health officials and school superintendents. We had a school closed in Oregon for a couple of days, healthcare providers, and everyone has emphasized the need for robust funding. And I'm glad we passed the bill with strong bipartisan support in the House here yesterday. I hope they get it over the finish line soon in the Senate. But I've also heard numerous concerns about the availability of protective equipment, particularly masks, also staffing challenges and testing capability. And we know those infected with COVID-19 can remain asymptomatic for several weeks. So healthcare professionals, as Dr. Hotez was talking about, are at even greater risk. There are furloughed healthcare workers in my district. The CDC just expanded its guidance for testing, but there's still a significant amount of confusion about who should get tested and how those increasing testing capabilities can best be used to inform and improve our response efforts. And we heard this morning South Korea is testing 15,000 people a day. Dr. Brownstein and Dr. Hotez, we can't get an accurate picture of the infection if we're not testing, but until recently the testing was limited to those who had recently traveled to places with high rates or those showing symptoms after close contact. So I understand the process of getting the tests out into the field is slow. We had the test sent to the CDC on Friday, and then it didn't come back till Tuesday, and that's really hard for a community that's wondering what's happening. So can you explain whether the scope of the CDC's guidance, was that based on best practices, or was it inappropriately limited because of lack of capacity to test, and who should be tested? Dr. Brownstein and Dr. Hotez.
Of course, it's hard to delve too deep into what was happening at the CDC at the time, but of course, increasing testing is incredibly important. We know that this is a mild condition. Oftentimes, people might be feeling symptoms. They may not even be interacting with a healthcare provider, and so we don't actually know the full scope of numbers of cases that are out there. And I think you mentioned a really great point about the impact on the health system. We are really advocating for opportunities to bring concepts like telemedicine and tools that help at the front line beyond the point where someone actually has to come in and end up in an emergency department. There's opportunities to think about tools that actually provide symptom checkers that integrate data from the CDC, but also have virtual visits with providers. This is a real important component because what we expect is an influx of people coming in to our health system. I work in a health system. We are very nervous about the flooding of our emergency departments with potential cases. So the opportunities to bring digital tools and innovative solutions along with the ability to integrate with testing, so home-based testing, other opportunities are really things that we advocate for because of the fact that, again, mild illness, lack of opportunities for someone to come and meet with someone live, and for the fact that we can actually begin to understand the depth of what's happening in the population. Again, those kind of data points are so critical now to understanding the features of this epidemic and to understand more broadly what's happening in the community.
Thank you, Dr. Hotez. As I mentioned, the test was presumptive on Friday, sent to the CDC. It didn't come back till Tuesday. Can you elaborate on some ideas? Why have we seen such delays in testing? Do you think this recent emergency use authorization will expedite things? And what else can we do to increase the availability and accelerate the testing?
So there are four brief points are around that, and thank you for that question. I think the first is testing for respiratory viruses is not trivial because you get oftentimes, and we've been seeing this in China, and this is actually not unusual. If you look at the literature on testing for respiratory viruses, you get a negative result, a negative result, negative result. You put the person out of quarantine, all of a sudden they're positive. what does that mean? Is it a true false negative, or is it because the test isn't sensitive enough? So it takes time to really fine-tune these diagnostic tests for respiratory viruses. And in fairness to the CDC, developing a new diagnostic test, just like developing a vaccine in the middle of a public health crisis, developing new technologies for a new agent in a public health crisis is one of the hardest things that we do as a nation. And it's hard to make that go quickly. I understand we could have done better. We should have done better as a country of getting those kits out there. I think we will get up to 1 million eventually, as I believe the Vice President mentioned. But until we do that, I think we've got to prioritize who gets tested. And my recommendation would be that we focus the testing strategically around protecting our 3 most vulnerable populations that I mentioned: our older residents and nursing homes and places of assisted living. They're highly vulnerable. The mortality among them is 10 to 15%. Healthcare providers, those who interact with the healthcare providers, and protecting our first responders, because if they go down, then again, everything collapses. But then, even after that, I think the other thing that not a lot of people are talking about, even then, is this is not adequate, right? If we have to wait hours or days for the test result, it's of limited use to us. What we need is like what we have now for a rapid flu test. We need to get a rapid test for that.
Thank you. My time's long expired. I yield back.
Thank you. Let me recognize the gentleman from Florida, Mr. Posey, for 5 minutes.
Thank you, Mr. Chair, for calling this an important hearing. I only regret that it conflicts with a members-only briefing on almost the exact same title taking place simultaneously. And thank you, witnesses, for the important work that you do every day, thinking about ways to combat public health threats. There's a common theme across your testimony, and that's pretty much when there's a crisis, all eyes turn to you. But when the disease of the crisis moves off the front pages, the public loses interest, and then the funding goes away. You didn't say this part, but I'll say this also, that when Washington sees a problem, the habit is to throw billions of dollars at it and say, look, now we've done our job, and hope for a good result, and move on to the next issue. And of course, there's always the finger pointing and blaming based on, as you well pointed out earlier, much information and disinformation. That's really regrettable, and I think the American people are getting a little tired of that. But Dr. Murray, working with partner agencies, you state you've successfully identified over 1,200 novel wild-borne illnesses, including 161 of which belong to the same family as COVID-19. I think most of us in the room are wondering what the risk to humans is from those viruses as well. I have 4 related questions that I'll ask you.
Thank you very much. I'll try and be quick in my response. So in addition to identifying the viruses, we also have a team of modelers who helps us identify where to look in the world. We also have a team of phylogenists and virology experts who then rank all these viruses. If we had enough money to look at every country, every species, every animal, we would, but we don't. So we really try and use funds effectively. So we identify the countries in which are most likely to be a problem, the species that are most likely to transmit lethal diseases to humans, primates, bats, and rodents. And then of those 1,200 viruses, they're ranked according to the families that are most likely to cause a problem for human health. And that's where we spend the majority of our time and resources. Influenzas, coronaviruses, filoviruses, and paramyxoviruses are some of the most important families. Just to add on to what my colleagues here have said, it is the time funds are an issue, and the program that I'm describing is just in the process of being closed down. We're actually holding our closeout session on March 17th at the Museum of American Indian, in case anybody would like to join us, because we'll be reporting on a lot of what we've done over the last 10 years. My suggestion would be this is not the time to lean out, but it would be the time that we need to be leaning in.
Yeah. What percentage of the viruses have the potential to jump to humans? Just swag it. I mean, just.
So of the 1.7 as yet unidentified viruses, about 50% of those have the potential to jump to humans, and that's based on the receptor sites and where they can attach to the trachea. Of those, but not all of those are going to spread rapidly, and not all of those are going to cause severe disease. So we look at, there's 50% that could jump to humans, and probably only 10% or 15 that can cause rapid disease and a pandemic. But until we identify those viruses, the species in which they occur, the reservoir species, and the mode of transmission to humans, we're really still at a tremendous risk. And then the research has shown that these outbreaks are coming more and more frequently. So while everybody, a lot of us have felt like, oh, this is a surprise, the folks in the health community have felt like this isn't a surprise. We've been saying it collectively for the last several years. These pandemics are coming. We can tell you in general, the countries or the areas, some of the risk factors, and some of the viral families.
Well, you answered my next two questions about the percentages already. So for the final question, how do you think we best prioritize research? You know, is there a good process to set research priorities in place?
I think a lot of what we're doing right here, and thank you for this hearing, it does bring everybody, a lot of the same folks into the room to help identify some of the issues. From my perspective, the more that we can look at bringing experts from many different fields, from the government, from NGOs and universities together, then that and the confluence of human physicians, well, most physicians are human, right? So human physicians, veterinarians, nursing staff, researchers, I think that's really what we need to be doing and looking at not only in the U.S., but in countries, in other countries as well, because we look at the economy globally, it's really time for us to look at health globally. So that's how I would go about establishing research priorities.
Thank you. That beats crisis du jour.
Thank you for your questions.
Thank you, Mr. Posey. The gentlelady from Texas, Ms. Fletcher, is recognized for 5 minutes.
Thank you, Chairman Barra. I want to get right to the questions. I thank all of you for being here for your testimony. It's very important. I want to follow up with you, Dr. Hotez, on your opening comments with a question and then open it up to the panel to weigh in with your thoughts. But kind of following up on what Mr. Posey asked as well, in your opening comments or your statement, you mentioned your work developing a vaccine for SARS, and you asked the question, what will the ecosystem be for vaccines that don't make money? And that seems to be an appropriate question for this committee and for the Congress of the United States to be tackling. So I would like to ask you what you think that ecosystem should look like, and then get others on the panel to weigh in on that question, and also touch a little bit on what Dr. Murray said about kind of the global nature and something we have discussed before as well. Where can we partner with other countries in doing this work, and where can we have a national response and a global response? I'd love to get your thoughts and then open it up to the panel.
Well, thank you very much for that question. I mean, there is some good news to this. You know, we're very blessed to have the National Institute of Allergy and Infectious Diseases, headed by Dr. Fauci, who's been very committed to this problem. And, you know, if it wasn't for NIAID and NIH, I wouldn't even be here, right? They've you know, really worked hard around trying to fix this problem. The issue is it's not enough, and it doesn't. And the problem is, you know, is if you talk to Tony, if you talk to Dr. Fauci, he'll say, look, Peter, I'm not a venture capitalist. I can't just hand over money. It's got to go through study sections. And the issue is the study sections oftentimes will get dinged and get turned down from an NIH grant because they'll claim what we're doing is not innovative. And they're often right. It's not innovative. We're trying to make a recombinant protein vaccine. It's boring, but it's absolutely essential. So we have to figure out a way for a funding mechanism to be created that will provide a steady funding for a base of scientists who are ready and able to develop a vaccine. Because we're over-reliant on the big pharmaceutical companies. They're not coming into this space in a big way, with a couple of exceptions. The biotechs, some of them are in it, most of them are in it, not so much for the specific vaccine, but it's a device to accelerate their technologies. So we've got to figure out a mechanism to create fund a group of scientists working in an area where they'll develop vaccines in the nonprofit sector. We've had Walter Reed Army Institute of Research for years. They've been hit very hard. We could restore that. That would be one way. We have this great VRC Vaccine Research Center at the NIH, and there's a couple of others like ours, the University of Maryland Center for Vaccine Development, our Baylor College of Medicine one, and Texas Children's. But each one has to be bigger, and each one has to be, and we need more of them as well.
I'll just add also my thanks to the NIH, because I also wouldn't be here without support from specifically the National Library of Medicine and their efforts to really train the next generation of data scientists in health. Specifically around your question around vaccines, I think it's really important to think about the comments of Dr. Murray and think about the next event, right? Of course, we need to be focused on the current coronavirus, but we're going to see likely another event, another likely coronavirus event. We saw SARS, MERS. It's likely that we should be thinking about universal vaccines around coronaviruses as opposed to maybe something very specific around this event that ultimately will prepare us for the next pandemic that we'll see in the future. I think the more that we can be thinking about those next events, and they will occur, the better off we'll be for the next one.
Thank you, Dr. Brownstein. Dr. Sell, you had a...
Yeah, I have one thing to add. So you asked about the ecosystem for vaccines that don't make money, right? We have the difficulties with developing those vaccines and then testing them. But we also, a project at our center led by Nancy Connell, we also have a problem with manufacturing those vaccines at scale, right? So we might be able to have a vaccine, but we can't make, 500 million doses or whatever we need quickly in enough time to make a difference. And so I think that's another thing. We can't just swap over the products in a manufacturing plant. That's another area that really needs a lot of attention.
Thank you. Dr. Murray, I have a 30 seconds left. I'd love to hear your thoughts.
I agree again with my colleagues, in particular what Dr. Brownstein was saying about the universal vaccine. I think it's a very good idea to invest in that. And again, part of the information we would collect in the field about what types of vaccines or what type of viruses are out there will hopefully help inform that. I also wanted to add on just I thought a little bit more about the question from Mr. Posey, and I do think that if we're going to be looking at research, creating a One Health program somewhere because we don't currently have a program that works in high-risk areas that incorporates both human expertise and wildlife expertise, and ideally has one foot in the federal government and one foot outside of the federal government. It would be great if such an institution were here somewhere in D.C., and perhaps a parastatal institution that already exists.
Thank you very much. I have gone over my time, so I will yield back.
Thank
you all.
Fletcher. The gentleman from Texas, Mr. Cloud, is recognized for 5 minutes.
Thank you, Chairman, and thank you all for being here to help us address this very important topic. I appreciate the healthy discussion over some of the misinformation that's come out sometimes with political goals in the dispersion of it. Also appreciate you educating us just really on some of the real scientific challenges in addressing a situation like this. I wanted to see, Dr. Murray, if in the effort of giving good communication on this, if you can give us kind of backtracking, give us kind of an understanding of why are we dealing this? Where did this coronavirus come from? How is it unique? How is it spreading?
Oh, thank you very much. I'd be happy to do that. And I think we could probably share the answer to that question as well. In terms of what we know are that bats, primates, and rodents are the species that are most likely to carry these viruses that transmit to humans, and the coronas in particular. And our team has already discovered several other coronaviruses in China with 97 to 98% homology to this virus, meaning so they're very closely related. And we also developed these trees so you can determine how closely this virus is related to the other coronas. We found some in Myanmar that are not closely related and not likely to cause disease. So and we also have behaviorists looking at what are the risks associated with bats. In a lot of countries, bats provide a lot of protein, and people do eat bats. But if you think through it, the risk might not be the person in a restaurant eating a fully cooked bat. Perhaps the risk is the women in the back who are preparing the bat without the gloves and without the masks and along with children, and then take it home. So trying to understand the cultural norms and human behavior patterns that that contribute to these sorts of things. A quick shout out to OSTP because we also have a pandemic preparedness forecasting science and technology panel that looks at these sorts of things. And collectively, this past year, we at Smithsonian hosted a two-day workshop looking at bringing together the soft sciences and the hard scientists, the modelers who look at human behavior and also the hard scientists that look at what the virus does. So we believe that wildlife markets and the wildlife trade are a really huge risk in general. And the risks are different whether you're in Africa or Asia. Africa, animals tend to come to the market. The risk is more in bushmeat trade for the folks that are in the forest that are killing the animals, and the meat tends to come to the market already dead, whereas in Asia, it's often live animals that are at the market. So those are to answer some of your questions about the virus. We believe that it's a bat-related virus and that it came in close contact through the markets. We still have so much more to learn about this virus in particular, and with epidemiologists and our human health folks as well. And so there's still so much we don't know, but that's what we know so far. I'd like to yield to any of our MD colleagues to see if they have something to add.
Well, if I may, I only have 2 minutes left. Dr.
Sorry.
Hotez, if you can tell us what's some of the challenges in addressing these treatment and vaccine. Also, I'm just going to get all the questions out here. Based on your experience working with SARS and Ebola and Zika, what are some of the challenges you've seen governments face in the past? What are some of the best practices we've learned? And what's some of the things that we can use toward addressing this? And then if you can answer that, and if there's any of you want to jump in and finish the timeout.
Yeah, two points. So we need more vaccines, and trying to do this in the middle of a crisis is very difficult, right? I mean, we have an N of 1, the story with Ebola, maybe cholera vaccines in Yemen. So we want to start doing this now. And one of the other problems that I'm seeing is through NIAID and BARDA, we have an incredible mechanism for supporting vaccines. So clearly the U.S. is the global leader in this. We need some of the other countries to start pitching in and help supporting global health technologies. If you look at the funding, public funding globally, the U.S. is by far the number one, the U.K. maybe second, the European Union, and then the bottom falls out. So we see a lot of underachievement among the G20 countries. China's doing very little. Japan, not much, a little bit. Korea's starting now. I'm on a board called the Korean Right Fund with the Gates Foundation. Brazil needs to step up. All the BRICS countries need to step up. So we really need to put this on the agenda of a G20 summit to say, look, the U.S. has globally taken the lead on recognizing this is a huge problem through NIAID and BARDA. The other countries need to step up. This needs to be on the topic of a G20 summit. I have a book. I like to write books. So one of the books I wrote is called Blue Marble Health, which actually finds this quite interesting finding. Overwhelmingly, most of the world's emerging and poverty-related neglected diseases are not necessarily in the poorest, most devastated countries of Africa. It's the G20 countries. It's the poor living among the wealthy, including 12 million Americans that suffer from neglected tropical diseases. So we need the other G20 to show some leadership and work with State Department and others on this.
Thank you, Dr. Hotez. The gentleman from California, Mr. McNerney, is recognized for 5 minutes.
Well, I thank the chairman, and I thank the witnesses this morning. Very useful and informative. Dr. Sell, how can social science aid us in understanding how to stop misinformation during outbreaks?
So misinformation during outbreaks is a big problem, and I think it's a very complex problem. So social science can help us understand what the best messages are to help people understand when the rumors they're seeing are false. So to improve our messaging, the type of ways we're trying to communicate with people, how to convince them of, the facts rather than to believe in these rumors. But I also think that that we need to actually develop an entire strategy here. We need to think about all the different stakeholders, right? We have tech companies, they need to be doing work. We have the public. The public, we can't just say the public should we think the public should figure out how to determine truth from falsehoods. But we also have government, we have news media, and we have public health. We all need to think about those stakeholders and everything they can do to deal with this problem.
Is there a specific area of research that would help develop those tools?
I mean, I think that looking into seeing what misinformation is out there, and then also the communications research that I do, I think that it's looking at what kind of ways we can solve that and the messages that are necessary. So that's social science research.
Okay, thank you. Dr. Hotez, I'm going to follow up on Ms. Fletcher's question. How do we incentivize pharma and biotechs to prioritize vaccine development?
Well, it's tough, and you know, I know I've been critical of the big pharmaceutical companies today, but I also have some great support as well. I mean, you know, what Merck and Company did for the Ebola vaccine is an extraordinary story, right? I mean, that vaccine ultimately, giving it to 200,000 people in DR Congo in the middle of a war and conflict, prevented a catastrophic epidemic that would have dwarfed the one in West Africa and would have destabilized the entire African continent. So we owe a real debt of gratitude to Merck and BARDA and the supporters that made that happen. But if you talk to some of the people at Merck offline, one of the things they'll tell me is, look, we didn't make money on this thing. We actually, depending on how you crunch the numbers, we actually might have lost money because we had to pull people from money-making projects in order to put them on this. So it's really a problem. Vaccines are expensive, and they're expensive because of all the quality control and quality assurance that you have to put in, and all the belts and suspenders you put in to ensure safety. So and that's maybe one of the reasons why we're not seeing the big pharmaceutical companies jump in this time around, because they saw, oh my God, look what Merck had to do in order to make this happen. So I think we have to look at creating a new type of organization, and maybe working this out in the nonprofit sector here in the United States.
Thank you. Dr. Brownstein, I'm pretty excited about the Health Map platform that you discussed. How is artificial intelligence used in public health preparedness to prevent spreads?
So AI is seeing a real explosion in the use in healthcare. Of course, we've seen advancements in other domains, financial services, entertainment. But what we see is there's opportunities in leveraging AI with large data sets. When we're dealing with an important event like a public health crisis, there's a huge amount of data, a lot of information about cases, a lot of misinformation, and being able to sort through all that critical data to get important insights that we can feed to our modelers, our policymakers, even the public. That's where these kind of methodologies come into play. So if you think about the earliest signs of the COVID-19 event, they are actually through these epidemic intelligence collecting tools, actually some that support the technologies that Dr. Murray was talking about, combing through the web, looking for signs of mysterious illnesses that we could utilize to then pinpoint and then communicate those to the World Health Organization and CDC and other organizations. But more importantly, there's a vast amount of information globally now being transmitted about cases confirmed, suspected, on trying to understand the response, the recovery, the demographic data of these patients. That is well more capacity than the existing workforce of epidemiologists that exists on this planet. And so what we're trying to do is augment the work of these public health practitioners through the opportunities that AI brings. So the opportunity to mine that information, organize it, and bring the situational awareness data to the forefront so it can be used effectively.
Okay, I'm running out of time. So I'm going to ask you for the record, not verbal response, what the challenges are in expanding AI into this field. So I yield back.
Thanks. The gentleman from Texas, Mr. Olson, is recognized for 5 minutes.
I thank the chair and welcome to our 4 expert witnesses. A special welcome to Dr. Peter Hotez. I'd like to join my Texas colleague, Mrs. Fletcher, in bragging about Dr. Hotez. My colleagues need to know this is not just a man who's an expert in Texas. He's a recognized expert in all of America and globally on pandemic viruses. And that's why you saw him all day yesterday on national cable explaining the challenges with the COVID-19 virus. You also saw him doing that with the Ebola, with SARS, with H1N1, and with Zika. H1N1 was very special back home. That broke out in 2009. and your institution, Texas Children's Hospital, set up a drive-through vaccine in a parking garage almost overnight to have those vaccines deployed. So again, thank you for being here. As Bum Phillips would say, you may not be in a class by yourself, whatever class you're in, it don't take long to call the roll. I want to talk about quality treatments and future responses. First, quality treatments. Yesterday it was announced that my home county of Fort Bend was the first site in Texas to have a confirmed case of the COVID-19 virus. The man, don't know too much, the man was 70 years old. He had traveled overseas, no confirmation, went to China, Iran, or Italy, and he's now quarantined in a local hospital. As Dr. Sell mentioned, a lot of people right now are living in fear that this disease is among the people of my hometown. And those fears may cause people to do something that's not very wise and sometimes very foolish. We've seen photos all across this country of towns reacting to this influenza. We've seen empty shelves of grocery stores. We've seen empty shelves of bleach. As you said, Dr. Sell, people think drinking bleach can somehow help control this virus, which is just crazy. We see empty shelves of canned foods. We see at the Home Depots, the Lowe's, all the masks and stuff that needed to protect people are getting swarmed up by people who don't need them. And Dr. Hotez, you brought this up yesterday on national TV. How can we make sure the required resources we have to fight back are given to the top priorities, which I think, as you mentioned, are probably, first of all, the families, the victim, their neighbors, the first responders, EMS vehicles, the cops, the firefighters, and also the doctors and nurses who take care of them. How can we make sure those people have the first priority to get these scarce resources?
So you've hit on it, right? I mean, that's exactly right, and thank you for those really generous comments. We need to give our 1, 2, 3, 4 top priorities of the groups that we're going to ensure, because if they go down, then everything falls apart and things go badly very quickly. And I don't know that we've really done that yet. So I think, protecting our older individuals in nursing homes, because we now know from Kirkland, any time a virus hits a community, those are the ones who are going to get hit the hardest, and the healthcare providers and others. The other thing I've been saying is regarding panic is, look, you will have time. It's not like you're going to wake up tomorrow morning and find that the entire eastern half of the United States is infected. What we're going to see is multiple communities being affected, and that will cause a lot of concern, but you will have time in order to prepare and figure out what's happening. And we don't exactly know. It may stop there. There's some who believe there may be seasonality to this virus. We don't know that at all because it's a new agent. So I think it's the key is to stay in our leaders need to stay in contact with the people, hold those White House briefings on a pretty regular basis, but also try not to sugarcoat, right? It's a real art to be able to give difficult information, but to do it in a way that say we're aware of it. Here's what we're doing about it. And I think we've been through this before. One of the things that I've noticed in the 20 years that I've been following pandemics, it started with anthrax in 2001, then SARS in 2003. H1N1 2009, as you point out, Ebola 2014, and then we go to Zika, and now this. The same thing happens every time. It takes us a little bit of time to get our arms around it. There are always stumbles in the beginning, and a lot of that has to do with the federal government and the state governments have to figure out all over again how to work together. So there's always seems to be that new relationship building that has to happen, and then eventually we get it right, and this will happen again. So, and that's I think the other thing that we want to see is the press not piling on too much when mistakes happen.
Good luck with that.
Yeah, I know, and well, especially it's occurring right during the Democratic primary. It's happening the worst time possible from that sense. And to have that perspective of time saying, look, this always happens with, I mean, it's the,
Thank-
it's the
thank you,
hardest
Dr.
thing our
Hood.
country does.
Thank you, Dr.
I hear the
Hurtas.
gavel bang. Have some questions for the record on stockpiling vaccines. Thank you very much.
Let me recognize the gentleman from Illinois, Mr. Caston.
Thank you, and thank you all for coming. I want to follow, if I could, a little bit on the questions Dr. Berra asked at the start about vaccine development. Dr. Hotez, thank you for clarifying that we're not going to have this vaccine for a year or so. Can you just share a little bit some of the risks of bringing a vaccine to market too early?
Thank you for that. Yes, well, the risk is compromising safety. Remember what we're doing. We're going to be immunizing healthy people, right? So vaccines always have a higher safety bar because you're injecting, well, people. These are often not individuals who are ill, and you're trying to accelerate some technology for compassionate use. And our FDA, our CBER, has one of the best track records in the world in ensuring safety, and we have one of the best monitoring systems in the world on ensuring safety. I mean, we have these 4 systems in place: the vaccine adverse reporting system. We have, and many times people think that's the only thing we have. We have a redundant system of four tracks that follow this. So we know how to do this. We know how to ensure that vaccines could be developed and tested safely. Don't try to pressure FDA CBER into doing something that breaks with that, because if we start rolling out a vaccine too quickly, and it's shown that a number of those individuals are getting worse because of this vaccine, which we know can happen with certain respiratory virus vaccines. We've seen it with RSV. We've seen it with in laboratory animals with other coronavirus vaccines. Then people will lose confidence, and not only confidence in the coronavirus vaccines, but our whole vaccines and safety network.
So with an unvaccinated population, given as some of the early data, seems to suggest that those who are most at risk are the elderly, immunocompromised. We're not going to have
and healthcare workers.
Yeah. So we're not going to have a vaccinated population. Presumably, other complications that people have may be at risk. As you look through sort of our broader healthcare ecosystem, do you see other medications that we may be where increasing focus on some of these non-coronavirus drugs may be the thing that is ultimately going to hurt people? Are there other places we should be looking in the ecosystem right now?
Well, remember, vaccines are the highest bar there is. So even though that's going to take, whatever time it is, there are other technologies out there that'll get deployed more quickly. I think we'll probably have antiviral drugs a little.
Sorry, I'm asking a sort of a different question, and maybe it's my own lack of knowledge. If I already, let's say, as an example, I'm taking immunosuppressants because I just had a liver transplant, and all of a sudden I come down with coronavirus. Coronavirus may not be the thing that does me in, but this other thing does. So if we look at the populations that are most at risk from getting a bad flu, are there other sort of drugs and pharmacologicals that community is disproportionately taking that we should be concerned about, or maybe a little focus there might protect some of these folks?
I don't know. Nothing. I'll have to think about that a little bit more. Okay. But you're right. I mean, I think we don't have. Remember, this is a new virus agent, and there are differences in the U.S. and the Chinese population. We haven't seen a lot of data of people with immunosuppressive drugs, so okay. I don't think we really know what that.
Yeah, just use that as an example.
People on Humira and all. I don't think.
Yeah, my concern is just all these people who might be needing insulin, might be needing statins, other things. Shifting with a little bit of time I have left, Dr. Sell, I appreciate your comments on not spreading misinformation, and just with the little time we have left, all of us are going to be back in our districts next week. We all have certain platforms that we can speak to. Given what you researched on Ebola, and without making this a political conversation, as you look at what's going on right now, are there specific pieces of misinformation that trouble you? And if you were in our shoes, what would you love to see us saying to the country this weekend?
You bring up something that's very important, because influencers like you have one of the biggest roles in spreading the truth about the disease. That's actually borne out by the research. So I think when you go home to your constituents this weekend, I think people might be afraid. And I think this is a concerning disease. We can't sugarcoat it. We have to say, this is serious. We need to think of it and think about the ways that we can prepare. Research has shown that people really want to know more about the actions that they can take rather than the risks that they have to worry about. And so, you know, the CDC has a lot of advice out there. Wash your hands, use respiratory etiquette. I think people also want to think about how they can be prepared, how they might take care of a loved one. If a loved one is sick, but not serious enough to be in the hospital and we're limiting how many people we're trying to take care of in hospitals, so how we might care for sick people at home, and think about, you know, stockpiling prescription meds and things that you might need, and you don't want to be at the store when there's, you know, a lot of sick people or whatever. I think that actions are really what people need to hear right now.
Thank you. I yield back.
The gentleman from Ohio, Mr. Gonzalez, is recognized for 5 minutes.
Thank you, Mr. Chairman, and thank you for our witnesses. Dr. Otez, you have a great background. I'm going to sing Dr. Sell's praises for a moment. It's not every day that we get an Olympic athlete in our midst, especially one that had a world record at one point. Do you still have it, by the way?
No, someone took it a couple years ago.
Still unbelievably impressive. I don't think any of us have world records in our history. Could be wrong. Certainly for nothing as impressive as what you did. But of all the accomplishments and things I respect most about Dr. Sell, it's the fact that she has my wife's unyielding admiration and appreciation that means the most to me as a college teammate of yours. I want to start by asking about the role that diagnostics play in forecasting accuracy. I just left a briefing where it's very obvious that we did not and still probably do not have the number of diagnostics available with respect to coronavirus today. So when it comes to your forecasting accuracy, what role does having robust diagnostics play in the process?
Well, that's a great question. Diagnostics, and thank you very much for the introduction. Diagnostics have an incredible role to play because the way that you look for information out there about the disease determines what you'll find, right? So if you're only looking for people who have a travel history, you're never going to say, oh, we have community transmission, because every case you find will have a travel history. And so I think that being able to use rapid diagnostics like the flu test or these other things, is really important so that we can know those more mild cases and we know the range of disease and where it is.
Great. And then, did you have, sorry.
No,
yeah.
From a modeling perspective, having an accurate understanding of what's happening in the community is incredibly important, right? Because we're essentially seeing some of the more severe cases. It might lead to overestimates of case fatality. We don't actually know what's happening at the community level because we don't have the testing. So we're going to essentially be biased in our understanding of the disease and not actually have a direct understanding of things like household transmission, what we're seeing in terms of the level of spread that's happening. So this is why having enough diagnostic capacity to do it at a population scale is so critical, and why we see incredible advances in Korea and other places.
Yeah, and I think that, you know, one of the things that is troubling for a lot of folks, certainly for me, is you see different case fatality rates depending on the country, right? And my estimation of that is it's because we don't know the N and everybody's using a different, you know, South Korea, they're testing all the time. It seems like almost like drive-through test kits. Whereas here, it's unclear to me how many people we've actually tested. I don't think it's north of 1,000. I could be wrong on that. So that's been a little troubling. I guess a follow-up question on the model piece. If we had been testing on the order of, say, South Korea, how much further along do you think we would be, and how much closer to being able to more effectively prepare and prevent a major outbreak would we be if we had the better testing capabilities? I'll start with Dr. Sell.
I'll be quick so the others can answer, but I think if we had better testing capabilities, I think we would have had the motivation to get moving a little bit quicker.
Yep.
And especially in places where we might see disease so that we could keep it out of those nursing homes and hospitals. So I think that would have been helpful.
Great. Dr. Brownstein.
Yeah, exactly the same thing. The more detailed information we have on the ground, the better off we are to respond. Models are only as good as the data that we feed them, of course. And so if we have richer information about what's happening, we had that testing, we can understand what is happening at the community level and think about things like social isolation and other mitigation efforts that could slow the spread of the coronavirus.
Thank you. And then with my final minute, Dr. Sell, I want to go back to the question that Mr. Caston was asking with respect to false information. Obviously, since 2014 in Ebola, the platforms that we use, the way we communicate has changed quite a bit. Have you noticed a difference a stark difference of any kind between how misinformation was spread in 2014 versus how it's spread today? What sort of lessons can we learn from that?
This is an opinion without an analysis behind it, but I think that the spread of misinformation has been much more rapid. We know that in some cases it's been coordinated, and I think that it spreads across multiple platforms very quickly. We have these echo chambers, and we had echo chambers in 2014, but where this information just bounces within people who have the same belief systems, and so it's very hard to change that.
Okay, thank you, and I yield back.
The gentleman from Illinois, Mr. Foster, is recognized for 5 minutes.
Thank you, Mr. Chairman, and to our witnesses. I've been sitting here trying to synthesize from your testimony what a coherent plan to actually, do something over the next decades that would really move the ball in this. And so the first step, it seems to me, is to actually characterize the up to 1.7 million potentially transmissible viruses. And I think there may be hope for developing technology so we can see the sort of, 1.7 million sounds like a big number, but with technology development, you might be able to bring the cost down. And then to potentially do things to mitigate transmission from the animal reservoirs. And, there are things like gene drives and other things. They just did, they're talking about releasing mosquitoes that can't transmit certain parasites. That sort of approach might be important. Secondly, to simply identify the conserved sequences across broad classes of these. There was an example of this actually in my district, Argonne National Labs, where they recently solved a protein called NSP15, which is conserved among coronaviruses, is apparently involved in the replication of the viruses and a very attractive drug target, but actually do something that would sort of persist over a time longer than Congress's attention deficit disorder, to actually, stay focused on a handful of attractive targets or a large number of attractive targets and develop these for drugs, both as treatments and vaccines. And here I perceive there's a real difference that you can potentially do things quickly for treatments, but the vaccine problem is much tougher because of the clinical trial bottleneck. I don't know if there are any great breakthrough ideas so that if you have thousands of potential viruses and everything about them understood, but you haven't done the clinical trials on them, and you identified targets, but you still need clinical trials, are there any ways to accelerate that, or any potential technologies out there? That seems like an unsolved problem from your testimonies. And then fourth, developing high-volume general-purpose manufacturing that's on standby, which is something Dr. Sell mentioned. This seems like it's something where you can throw money at the problem. If there are really general-purpose technologies out there, and there's a lot of overlap with this, frankly, with money we're spending on bioterror defense, and it may be that's the exact same equipment that you need. And so I'd be interested in, well, first off, have I missed any big parts of this? Are there significant things? I think the rapid detection is something you mentioned that's sort of a parallel track from this.
If I may add just one other component to this, which is this idea of a national or international service around disease forecasting, right? We've done this for the weather, right? Like a national service for weather where we collect data from NOAA and make predictions. That does not exist today in disease forecasting, and if there was investments to be made in addition to important pipelines around manufacturing, it would be developing a way to predict the next coronavirus-like pandemic.
Yes, Dr. Hotez.
Yeah, I think you point out a very good bottleneck that that clinical testing does take time. There has been a lot of effort to apply innovation towards streamlining clinical safety testing. Sometimes we call it systems vaccinology. The idea is we can do more things in parallel rather than sequentially. And in fact, that was already started with the Ebola vaccine in DR Congo. We did a lot of things in parallel, so it really went through and we got information on its efficacy and its safety in record time. And I think if it wasn't for this particular safety signal around this immune enhancement problem, we might have broken a record, because there is an appetite to figure out how to streamline vaccine safety testing. It's just that there's just unique, quirky feature about coronavirus vaccines and some other respiratory virus vaccines. So I think you will see innovation in streamlining clinical trials. I'm just not sure this is the one to do it with.
I had one other addition. I think that when we come up with these tools, they're interesting and they exist out there, but we really need a way to sort of integrate them into practice. And so I think practice-focused research at public health agencies and the CDC is really important to making sure that we actually move research into actually making a difference on the ground.
And have there been, big studies that actually come up with, here's the holistic plan, here's the rough budgets? Is this something where it was done 15 years ago by the National Academies and ignored by Congress? Or is that there actually the need for, okay, let's just sit down and in an international context come up with a plan that has those elements that I mentioned and others? Dr. Murray?
Yes, if I can answer part of that. To answer the first part of your question, there is a group that's newly formed, the Global Virome Project, that is looking at the 1.7 million as yet unknown viruses. Their goal is to identify and characterize all of that, much in the same way as the Human Genome Project started out and provided a wealth of information. We have had for the last 10 years a global program looking at human and animal health, as well as syndromic surveillance in country, laboratory building. That's the one I was describing that's just in the process of shutting down now. I would suggest that this is not the time for the U.S. to be pulling out, but if we have a program that's doing it, if anything else, we need to continue and expand and incorporate more of the type of folks we have here. And part of that program also had what Dr. Sell was working on.
I'm sorry,
too.
I guess I'm exceeding time here.
We're going to try to get one last question in since they called votes on us. The gentleman from Virginia, Mr. Byers, recognized.
Mr. Chairman, thank you very much, and thank you all so much for being here. This incredibly important topic. And as Dr. Hotez, it's nice to see you again. 30 years after first coming across your incredible landmark work on the hookworm vaccine, so good luck. I want to start by submitting a letter I led yesterday, supported by 60 members of Congress, sharing my concern about the ineffective White House response, the lack of a chain of command, sharing of conflicting information, et cetera. So, and how we stand ready to improve it. So, if there's no objection, Mr. Chairman. And Dr. Sell, first with apologies, I hate asking yes or no questions because they tend to be gotcha questions here. So please know that time allowing, there'll be time for paragraph questions later. But I'd like to make just a quick point, so 5 yes and no questions would be helpful, okay. And then we'll move. First, the World Health Organization says that the death rate from coronavirus is over 3% of those infected. Do you have any reason to believe that the actual figure is a fraction of 1%?
A fraction of 1%?
Yeah.
Yes.
Okay, thank you. Would you say that the World Health Organization statistics on the spread of the novel coronavirus are false?
No.
Will we have a vaccine soon or within a few months?
No.
Are we likely to get a quick cure?
By cure, do you mean a treatment?
Well,
I would have to say possibly because there's drug trials.
Okay, great. And should Americans who have the coronavirus symptoms or believe themselves to be sick go to work and risk spreading the disease?
No.
Would you generally agree that all these statements are false? The panel. Well, let me go on. Dr. Sell, one last question. Would you say that it would endanger American lives to spread disinformation that would cause people to go to work and potentially spread the coronavirus because the public was misled about the dangers of this deadly disease?
Misleading the public about the disease is wrong.
And so the sad part here is these statements, which most scientists, well, think every scientist testifying today would agree endanger American lives, were actually made by our president to large audiences in the last 3 days. Scientists just told me that Trump's coronavirus statements about a quick vaccine, a quick cure, it's okay to go to work, that all these things are endangering American lives. And to be clear, the CDC advises anyone exhibiting symptoms of coronavirus, such as a fever, coughing, or shortness of breath, stay home from work, avoid public areas as much as possible, and seek medical attention. The Tuesday briefing from Vice President was not televised. He came here and talked, I think, 4 different times. On Monday, we heard reports that the CDC stopped disclosing the stats on how many Americans are being tested. At a time of high uncertainty in the face of the likely pandemic, should the American administration be more transparent or less? Maybe Dr. Hotez or Dr. Sell?
I'll just be quick. The administration should be transparent. They should be clear about what they know. They should tell the truth, be clear about what they don't know, what they're doing to try to find out those missing pieces of information, and be clear about what the course is and what information might change that course.
Thank you, thank you. Dr. Brownstein, we've heard a claim that focusing on testing is no longer needed once the disease is spread, that it's in the community, that testing is moot. We've also heard that sentiment from many that they'd rather over-test folks than under-test folks. Do you think that testing will still be valuable when it starts to spread into a community?
Yeah, I think it's important to actually have an accurate picture because the dynamic of this virus is going to change as it moves from community to community, and understanding the impact that it's having at scale is going to be critical. And so just like we do this for the influenza on a seasonal basis where we test for flu to understand what the underlying illness is, the idea of doing this at scale for coronavirus makes a lot of sense.
Yeah. Dr. Hotez, you've done so much work on vaccines over the decades, and you've testified earlier quite well about it. What's the best the American people can hope for in terms of a quick vaccine or a soon vaccine?
Well, I think it's really important to remember that vaccines are not quick, and that has a lot to do with vaccine confidence in the United States, because as you know, we have a very aggressive anti-vaccine movement here in this country, and as of the last couple of years, it's affecting public health, right? Measles came back in 2019 because of the anti-vaccine movement. Historically, when we've had measles epidemics, it peaks now, late winter, early spring, so we may be battling two epidemics. We still have 16,000 Americans who've died of flu, including 100 kids, most who are not vaccinated. So I think it's really important not to tell the American public that we will have a quick vaccine, because that's not how it works. We have to reassure the public that we don't give out vaccines unless they're thoroughly tested, and they are the most thoroughly tested pharmaceuticals we have for safety.
And Mr. Chairman, as I yield back, I just want to thank Dr. Hotez, too, for leading the fight against the anti-vaxxers and that misinformation.
Thank you, Mr. Breyer. Before we bring this hearing to a close, I want to thank all of our witnesses for testifying before the committee today. The record will remain open for 2 weeks for additional statements from members and for any additional questions the committee may ask of the witnesses. With that, the witnesses are excused, and this hearing is now adjourned.